adaptation.
Hello, hello! Good to see you, although I would prefer to be in Mexico with you. My talk here will ask the fundamental question: do we need ARDS? Do we need the letters? Do we need the syndrome? And it's a question that I like to raise because I think the answer is actually quite complex. We know that the ARDS is just a syndrome, acute respiratory distress syndrome, and it can be due to many events. Sepsis in the lung or elsewhere, aspiration of gastric contents, trauma, near drowning, etc., etc. What is ARDS? Is it a form of respiratory failure with hypoxemia, bilateral chest infiltration? These are criteria. We often confuse definition and criteria. The definition is that it is acute lung edema, which is not due simply to an increase in hydrostatic pressures like in left heart failure or in hypervolemia or a combination of the two. It's important because the criteria may change. A myocardial infarction is a clot in the coronary artery. In the past, there was no reference to troponin levels, but today we would still not define myocardial infarction as something with a high troponin level. So the criteria for ARDS may change over time, and we may revisit them now that we use more high-flow nasal oxygenation. Sepsis. It's infection plus some degree of organ dysfunction. These are the criteria. But sepsis is a deleterious host response leading to organ dysfunction. And shock is a form of acute circulatory failure. You should not define shock by hypotension, oliguria, increased lactate level. So it's important to have a clear mind. You know, when we designed the so-called Berlin criteria, we had long discussions about what we would put there, and these are criteria. So it doesn't tell us very much about the cause of ARDS. And that's the reason why, even though I was part of the consensus meeting, I'm still not sure about the quality of this concept, because for clinical trials, it has not helped. Syndromes are not diseases, and survival depends on identification of the cause. So we need to individualize ARDS as much as we can. ARDS is an alteration in capillary permeability at the end, resulting in altered gas exchange, bilateral chest infiltrates of left heart failure. Do we identify it well? Well, you may remember this study conducted several years ago now with 29,000 ICU patients. And ARDS could be separated in mild, moderate, severe, but the point is that clinicians often do not recognize ARDS. And many people present this at meetings. They say, you see, you don't identify ARDS correctly. And I say, so what? What is the problem? When a resident describes a patient, and when the criteria for ARDS are there, when I say, but this patient has ARDS, the resident does like this. Oh, yeah. I say, don't worry. Just ask. Because the respiratory management is the same as in other forms of respiratory failure. Oh, no, you need to protect the lungs. You need to limit tidal volumes. I know this beautiful study showing that a high tidal volume is associated with worse outcomes than a relatively normal tidal volume. That's the message of this paper. We can harm the patient when we use large tidal volumes. But now we know that this is true in the absence of ARDS as well. This is an old meta-analysis. It's now very well accepted. There have been several meta-analyses. The evidence is there to indicate that with or without ARDS, we always need to limit tidal volume. Now, even during surgery, maybe, as suggested by Dr. Futier and collaborators here, there are more complications when you use large tidal volumes during major surgery. So always use low tidal volumes. ARDS will not change it. Of course, if the lungs are very inflamed, then the danger is even greater than if the lungs are not inflamed. But we know that we need to try to keep the lungs open with sufficient PEEP level and avoid over-distension. So it's important to try to open the alveoli, to recruit alveoli and avoid excessive ventilation of parts of the lungs. I wrote this editorial about high-frequency ventilation, and I show this because trying to use new modes of ventilation do not help very much. And high-frequency ventilation or high-frequency oscillation have not helped much. Pharmacologic management, what has worked in ARDS? What kind of medications? We have tried many things. You could argue that maybe corticosteroids in some patients with ARDS could be helpful because there is too much inflammation. But what we need the most is an endothelial protective agent. And that's not so easy. The latest molecule we tried was interferon beta, which can increase local adenosine production. But in this study, we could not show any benefit in patients with ARDS in a larger trial. So we are left without specific pharmacological intervention. Some time ago, people would have said, you can paralyze these patients. These are old pictures of patients who were sedated and paralyzed because of the ARDS. And indeed, there was a study from Papazian showing an improved mortality, improved survival when we apply this strategy. But why would we apply it in every single ARDS patient? Why can't we individualize these decisions? So I was very pleased to see this negative trial from the NIH PETAL network showing no improvement whatsoever. So, should we stop giving it? Well, maybe not. The message is not that it works or it doesn't work. The message is that it may work in some patients, but be deleterious in others. So that when we look at groups of patients, there is no improvement in survival. It means that patient management should be individualized. If you see a patient who may have excessive swings in intrathoracic pressures, then we could use muscle relaxants, but not routinely. Look at the harm that it may produce with more ICU-acquired weakness, with more serious adverse events. It's not a minor decision to give muscle relaxants. So if there is silly, self-inflicted lung injury from discoordination in the breathing pattern of the patient, yes, that would be an indication, but not in all patients. We need to consider the benefit risk. With paralysis, less silly, but more neuromuscular weakness. Otherwise, we learned that we should try to optimize sedation in every single patient using the early cash concept. Comfort, yes. With analgesia when needed, yes. But minimal or no sedation. Humanized care, yeah. Let's talk to the patient. Let's reassure the patient. Let's try to ambulate the patient as soon as we can. Fluid management. That's important. There is edema in the lungs, so you need to give diuretics. Ooh, yes and no. If the patient has no hemodynamic problem, yeah, maybe. Or at least we should avoid hypervolemia in all cases. But we should not forget that diuretics have an inverse effect than fluids on the Frank-Starling relationship. So we could decrease cardiac output. Decrease cardiac output, decrease oxygen delivery to the organs. That could be very harmful. Remember this now old study looking at conservative versus liberal fluid management in RDS? Well, these patients were basically stable, so that it could indeed reduce the duration of mechanical ventilation without major harm, except that several months later, you can see that patients were in the restrictive fluid management group more often had an impaired cognitive impairment. Wow! That suggests that brain perfusion was decreased. So you may decrease the duration of mechanical ventilation, but be careful. Watch the brain, perhaps the kidneys, if there is tissue hypoperfusion. So we need first to recall the phase where we are. Is it the optimization phase or the stabilization de-escalation phase? In the stabilization de-escalation phase, we can limit fluid administration and give diuretics, but not when tissue perfusion is still compromised. Then we need fluids to maintain a sufficient cardiac output. Of course, we don't want to amplify the degree of edema. Of course, we don't want to do that. So what we need is a fluid challenge. We can look at this paper published very recently where Debacker, Kecconi, and I briefly described how to do it. How to make sure that the patient is on the Frank-Starling relationship. And basically, we give a small amount of fluid and we look at changes in cardiac output that may be associated with that bolus of fluid. If the cardiac output increases, if there is no excessive danger, then we can repeat the fluid administration. Otherwise, we stop it. We stop giving fluids. Professor Tabou may argue that we could do an internal fluid challenge with passive leg raising, but it's the same thing, except that the passive leg raising test will bring less fluids and the signal may be less significant. But you still look at the change in stroke volume and cardiac output. What is the cause of ARDS? No, what is the cause of ARDS and what is the cause of death in ARDS? Death may actually be due to the underlying cause much more than to the ARDS itself, especially now that we have ECMO available. So we could use it in a relatively young individual with potentially reversible causes. So we should not really die of ARDS. And if we look at autopsies, do we find something specific? No, really. At the end, it should be diffuse alveolar damage in all cases, regardless of the etiology. But it's not necessarily the case. Already more than 15 years ago, Dr. Esteban showed that diffuse alveolar damage is often absent at autopsy. With Dr. DeHampton, we reached the same conclusion in our department where we do autopsies on a routine basis. It's amazing. Out of 64 patients with established ARDS, 1/2 exactly had the diffuse alveolar damage pattern, and 1/2 did not. So, even in autopsy, it's not a single entity. And Dr. Thiel observed the same findings. Diffuse alveolar damage in about 1/2 of the cases. And speaking about heterogeneity, but today we could speak about COVID-19, which is a single disease. And in COVID-19, we know all the discussions about ARDS. Well, first of all, the acute respiratory failure usually appears more than 1 week after the initiation of the viral disease. So it's no longer ARDS. But okay. The point is that CT scans do not always show the typical diffuse alveolar patterns. The compliance is not always decreased. So even in a single disease, acute respiratory failure can be somewhat heterogeneous. And that is why Professor Gattinoni and colleagues referred to type 1 respiratory failure and type 2 respiratory failure. This is open access. You can find it easily. And it shows you that COVID-19 is not a straightforward disease. And I had the chance to contribute to this Italian study of Dr. Caselli, and we found that basically in severe ARDS, the compliance is not always reduced. So the management should be individualized. We found in our own series of autopsies that there is nothing specific in any organ. Early diffuse alveolar damage is usually present, but not always, and the viral alterations are present in all organs of the body. COVID-19 is a viral sepsis with endotheliopathy involving the lungs, involving the other organs. So, at the end, there are problems with ARDS. Acute is not always so acute. The risk factors are not really included. The PF ratio may be influenced by different FiO2 levels. It's not a constant ratio. And, of course, the PEEP can influence it. There may be an influence of high flow nasal oxygenation, as I said. And some patients may have some hydrostatic alterations, and we may not identify that. And the chest x-rays are often difficult to interpret. It's not always so homogeneous. It's more significant at the left side than the right side, etc., etc. And at autopsy, only about 1/2 of the patients have the typical diffuse alveolar damage, DAD. In terms of management, there is no specificity. We should always limit tidal volume. We should always use some PEEP to avoid high FiO2 that could be harmful to the lungs. We should always consider the patient positioning. I have not mentioned that because prone positioning is reserved to the very severe cases, and we don't miss the very severe cases of ARDS. So we will not miss the patients who could benefit from prone positioning. They typically have a PF ratio below 150. And we should always avoid fluid overload. That's why the fluid challenge technique applies to every single patient. And if we diagnose, if we recognize ARDS, it does not imply anything. I must say at the end that I like to use the word or the letters ARDS. When I make rounds in your unit, I find a great heterogeneity in the patient populations, and I love it. I love it. That's why I love intensive care medicine. It's never boring. It's never the application of protocols that would be the same for every single patient. So, saying that the patient has sepsis does not really change the management, except that it shows it's a severe problem. Saying that the patient has ARDS does not change the management, except to say that this is severe. But when you say that the patient has ARDS, I know what we will look at. I know what the problems will be. These problems of oxygenation, of adequate PEEP, of adequate fluid balance for looking at the source, etc., etc. So by these 4 letters, I already know quite a bit about the discussion. So ARDS may tell us that the situation is severe, and that we need to find a cause if it's not COVID, where it's straightforward. If it's something in the abdomen, something else, I don't know what, I will look for it. But the risk, and that's in red on the graph here, is that I have identified ARDS, and now I will try to find the best people, and I forgot about the cause, because I will think that ARDS is a disease. That would be very, very bad. ARDS is not a disease. We need to personalize our strategies, and that's a recurrent theme in critical care medicine today. So we need to identify phenotypes, and Dr. Calfee and others have helped to show that, for instance, if you consider a statin administration, there are some patients who may benefit and some patients who may actually be harmed, because statin has anti-inflammatory effects. So if there is a strong hyper-inflammatory response, then statins may be indicated. If it's not the case, we should not give it. So that's important. We should not find a treatment for all ARDS patients. The same is true for fluid administration, though here actually they reverted the two groups and they found that Group A was Group B and Group B was Group A. So it's not so easy. It's not an easy approach, but we are getting there, trying to find simple variables that could help to orient our therapies. And that's really the way to go. Is it a hypoinflammatory phenotype or a hyperinflammatory phenotype? Corticosteroids, other anti-inflammatory strategies. That's for the hyperinflammatory type. So we need to better identify the right patient for the right treatment. And that's really the future of ICU treatments. As we wrote with Dr. Slutsky and Gattinoni, we can really personalize our therapies. And that's the reason why recently Dr. Slutsky and I say that we have never seen a patient with ARDS. Of course, it's provocative. It's because we have seen patients with many underlying diseases that could lead to ARDS, but ARDS only. We never see ARDS only. It could be COVID, it could be something else. ARDS is superimposed to a given disease. Muchas gracias. Thank you.